Hello, ladies and gentlemen, and welcome. Thank you very much for joining us. I'm Dr. Derrick DeSilva. I am the chairman of the planning committee here at AMMG. We're in Las Vegas, Nevada. We're at the Bellagio Hotel, and it's a pleasure to have with me this morning Dr. Erika Schwartz. Erika, tell me a little bit about, I know you're from New York. Tell me a little bit about yourself and what you do.
Tell you about New York?
Tell me about New York.
No, I have to tell you about AMMG. I think it's one of the best, it's probably the best of the groups that actually cares about the patients and about providing education for the physicians to help them really get the best well-rounded education as far as prevention is concerned and age management.
Well, we really thank you for being here, being part of our faculty.
I appreciate it.
You are one of the experts. I mean, you're an international expert in polycystic ovarian disease, PCOS. Can you tell us a little bit about PCOS, what it is and what your approach is?
Well, I think unfortunately PCOS is kind of misrepresented in the United States. And there's a debate between Europe and the United States about PCOS because most physicians just diagnose PCOS when they see a chunky little girl with hair, hirsutism, a lot of hair, and who has high androgen levels and doesn't have regular periods. The problem is that only 50% of PCOS patients are overweight. And then the other thing is that PCOS doesn't necessarily become diabetes, doesn't necessarily become bad things, doesn't necessarily mean infertility. It's actually, in a way, it's Mother Nature's way of protecting fertility because PCOS patients, when they get older, become more fertile. So PCOS kind of changes. It has a lot of phenotypes and it changes over time. So what we need to know is that, first of all, don't put a diagnosis or label on anybody because it's really scary and it's not nice. It's better to work with the patient, and the most important way to actually improve and help the outcome is to have them lose weight if they're in the 50% that is overweight. Otherwise, because there's insulin resistance associated with it, what you want to do is really make sure that they eat, glycemic index appropriate foods.
Low glycemic index.
Yeah.
Right.
So what they do is they stay away from sugar. But in general, exercise, like everything else, diet, like everything else, improves outcome. It's not a foregone conclusion that a 14-year-old who's overweight, hairy, doesn't have regular periods is going to become sicker as they get older.
So what is your approach? How do you approach these people? Yes, you said diet, exercise. At what point do you intervene with other modalities, hormones, medications, etc.?
Well, I think it's a holistic view, and that's why AMMG is so great, because it's all holistic. You look at the whole patient. So the first thing I address them with is kindness and respect, and trying not to put a label on them, because mothers and daughters come in flying into my office saying, I was just diagnosed with PCOS, and it's scary.
Do they feel helpless?
Of course they do. They feel like they're going to carry this for the rest of their lives. They don't have to. The thing is that if they're overweight, they have irregular periods, they have some hair, all you do is teach them how to lose weight, teach them how to accept the fact that they may not be exactly like everybody else. We do some tests to see where they are as far as testosterone levels. Their testosterone levels are usually higher because their SHBG levels are low.
And what is SHBG?
Sex hormone binding globulin.
Okay.
And because of that, so if you do things that will increase the SHBG, it will bind the testosterone and they'll have lower testosterone.
And what are some of those things that we can
diet
do?
And exercise.
That nasty thing that we call diet and
it's
exercise.
So important. And the more balanced you are, alkaline diets that are high in non-animal fat like coconut oil, avocados, and supplements like omega-3 fish oils, and there's then diindolylmethane, indole 3-carbinol, there are all kinds of supplements that will actually help. And over time, sometimes you have to intervene. I don't like to intervene with birth control pills because no study has ever proven that it does anything. What does help is really insulin supporting
agents.
No, it's not insulin supporting. It's like, insulin stimulating, whatever.
Right.
Anyway, what really helps is metformin or glucophage. And giving them metformin or glucophage, if they can tolerate it, blood form and glucophage being the same.
Right.
If it works and if it helps them, it helps them lose weight, it helps with the insulin resistance, and it helps them feel better. So that's probably the only thing that I would bring in. Sometimes you have to bring in thyroid, and sometimes you'll have to bring in progesterone. But that's really if you know what you're doing, and you don't want to encourage people to do things if they don't know what they're doing.
Now, do these? There's also a feeling that I'm never going to have babies. I'm never going to get pregnant. Can you address that issue also?
Of course. First of all, there's no such thing. Infertility is early on, and as I said to you before, it's like Mother Nature's way of protecting over the long run. So it saves these women, so they become more fertile in their 40s than other women. So as PCOS starts kind of receding, the fertility increases.
Why does the PCOS start receding? Is there a hormonal piece to that?
There's always a hormonal piece to everything, but what happens is that if you take, there are like criteria for diagnosing it, like the NIH in 1990, the Rotterdam in 2006, and then there's a kind of a combination in recently, which is an American combination. But the thing is that unless you really have ovaries that are really big, more than 12 milliliters, they have more than 10 to 12 cysts in them, you really can't diagnose it. And very, thick, dense stroma. You can't really diagnose it. And so we diagnose it willy-nilly a lot. There's no reason to really diagnose them that much. So as they get older, these cysts will disappear. And as hormones affect them over time, and if they take care of themselves, they get better. And as they get better, they become fertile.
So give me a 30-second wrap-up on PCOS, your view, your approach.
PCOS is a syndrome that affects genetically. Let me go back. So PCOS is a syndrome. It affects women, younger women, by making them obese, infertile. Actually, the first thing is hyperandrogenemia. So let's try again.
Okay,
the whole
that's fine.
thing. So let's see.
So let me ask you a question.
Yeah.
So give me a 30-second wrap-up on PCOS, your approach, and how you deal with these patients in your practice.
So PCOS is a syndrome. It's ill-defined. It may be genetic. It affects young women more than older women. It is primarily hirsutism, meaning hair, high androgen levels, and obesity is about less than half of them. These people do really well with diet, exercise, lifestyle changes, not intimidating them, not scaring them. Then you can give them metformin if necessary, and progesterone and thyroid if necessary. But over time, Mother Nature takes care of these people. They become fertile as they get older.
Love and support. That's what it's all about.
Always.
Thank you so much for joining us, Dr. Schwartz.
Thank you.
And folks, thank you very much for spending some time with us today. I'm Dr. Derrick DeSilva, and may you always be blessed with good health.